Today we'll talk about a case with cluster headache. Cluster headache is a primary neurovascular headache disorder. The exact pathophysiology is unknown. Cluster headache is a common presentation in the primary health care and as well as in the emergency settings. A patient with cluster headache experiences severe, strictly unilateral pain around the temporal, orbital and supraorbital area. The attacks are usually associated with one or more following symptoms such as conjunctival injection, lacrimation, nasal congestion, rhinorrhea, forehead and facial sweating, miosis, ptosis, and eyelid edema. These symptoms are associated on the ipsilateral side. We'll continue with our case. So our patient Roger, who is aged 54, he has had severe intermittent headaches for over 20 years. These headaches are characterized by an intense burning pain on right side of his head, accompanied by tearing in the same eye and a runny nose. When they strike, the attacks typically occur several times a day, usually last about an hour. Roger can be headache-free for months at a time, but the attacks always return. He has sought advice from multiple healthcare providers, but there has been no improvement as of yet. So when the attack happened, the pain is so severe that the patient says that he could feel something pulsating under the right side of his head, with his right eyelid swollen and red and his right eye injected and teary. The patient explains that these headaches have continued and have always seemed to start after he wakes up from his nap, which is around 5 p.m. When asked if lying down reduces his symptoms, the patient explained that lying down actually made the pain worse and he is forced to pace around. However, when the patient asked if his pain have ever increased during an attack, the patient reports that the pain seems to be constant in intensity. In addition, the patient denies any increase in symptom while staring at the lights. Roger denied feeling nauseous, dizzy, or confused when the attack happened. So his past medical history includes hypertension and diabetes type 2, and his family history includes DM and hypertension as well. He is a smoker. He's a 1 pack per day smoker and he drinks 1 to 2 beer a day. Actually, smoking and male gender is a big risk factor for cluster headaches. The patient was in distress and was pacing around the room and was quite agitated and in severe pain. His heart rate was 88, his blood pressure was 122/80, his respiratory rate was 16, his pain scale during the attack is usually 9 out of 10, senses intact, reflexes intact. Examination showed right-sided reclamation, conjunctival injection, rhinorrhea and congestion, ptosis, miosis and anhidrosis, facial flushing, right-sided scalp and facial tenderness. So the workup is based mainly on history and physical findings. History of attacks that occur with the characteristic periodicity and rhythmicity is the key to the diagnosis. Laboratory studies are not of any particular value in this regard. Roger's most recent therapy regimen had included lithium for prevention and a nasal spray of triptan for abortive therapy. Unfortunately, he reported little or no help from these therapies. We weaned him off the lithium and started him on irinotecan for preventive therapy. Irinotecan is a vasoconstrictor of peripheral and cranial blood vessels. For abortive therapy, we decided to try a sphenopalatine ganglion block. The SPG is a large collection of nerves located behind the nose, which acts as an important relay center for the autonomic nervous system. Because cluster headaches primarily occur in males who smoke heavily, several experts believe that SPG is consistently irritated in heavy smokers and eventually become hyperactive, usually on one side. Blocking the SPG with a local anesthetic has been shown to be effective in the relief of a wide variety of headaches. On the left side, you can see how the SPG block works. Actually, there are several ways to block the SPG, but the transnasal approach is the preferred technique. While the patient is lying down, 2 cotton applicators are soaked with 4% lidocaine solution and advanced into the nose on the side of the head pane and into the nasal passages. It takes an effect in less than 3 minutes. If the block is successful, there are no side effects. Patient can be taught to perform the blocks by themselves. The main step in the management of cluster headaches is the prevention of the triggers which are known to cause exacerbation of cluster headaches. In this patient, we advised him to avoid the triggers as much as possible, especially any disturbance in his sleep cycle, any strong emotions, any excessive physical activity can also induce attacks. He was also advised to quit smoking. Fortunately, our treatment regimen for Roger this time was a success. So after 2 months of learning the technique, Roger came back to us. He reported using the block several times with excellent relief of his headache. On one occasion, Roger felt the onset of severe cluster headache while golfing. He proceeded to sit down in the golf cart and block his SPG. Roger finished his round of golf headache free. So here we have come to the end of our slide. Thank you so much for your attention.